We are the Center for Advancing Health Outcomes. Research that transforms care, policy, practice, lives. Visit us at advancinghealth.ca.
Hey there, my name is Frank Schermeyer. I'm one of the emergency physicians, and more importantly, I'm a colleague of Dr. Andrew Kestler, who is going to be giving the talk today. Dr. Kestler is an emergency physician at St. Paul's of Vancouver General Hospital in Vancouver, one of the very few physicians to do that, and a clinical professor of emergency medicine. He has additional training in healthcare administration, public health, and tropical medicine. His current research and quality improvement projects focus on emergency department interventions for patients with opioid use at the local, regional, and national levels. He's the Vancouver Coastal Health Regional Emergency Department Addictions Lead and a leadership group member of an implementation science program at the CIHR-funded Canadian Research Initiative on Substance Misuse. Thank you, Dr. Kestler.
Thanks, Frank, for that kind introduction. Is sound working okay? Confirmation? Yeah. Thank you. And thanks all for those of you who are joining in person. I know it's sunny out there and probably you want some vitamin D. And thanks for those who are joining online. As Frank mentioned, I'm an emergency physician. I also have a role with the region in implementing programs in emergency departments. And I'd like to share with you some of my research, both and programmatic work, past, current, and future as it relates to interventions for people who use opioids in emergency departments. I have no significant conflicts of interest to disclose. I do get some grant funding, and I do have some funding from the region as well for my implementation work. I think we're all too familiar with this problem here. From the emergency department perspective, in any case, just to fill you in a little bit, we see people come in and out all the time who are dealing with substance use, particularly opioids, and we try to connect them with services in the community. Sometimes that works, sometimes that doesn't. They face difficult social situations, and they often end up in the emergency department. And as bad as that cycle is, it can get worse. People can actually spin out of that cycle and die. And as you are probably aware from the recent statistics released just in the last couple of weeks, 2023 was another record-breaking year in terms of the number of fatalities, so over 2,500. So that's what we're dealing with, and this is where we hope to intervene. From the work of a colleague at VGH, Jessica Moe, we know that people who come to the emergency department with opioid use are at particularly high short-term mortality risk. If you look specifically at those who presented with an opioid poisoning and also left without being seen, which is unfortunately a frequent occurrence, they had an 8% one-year mortality. So very high mortality in this patient population. We have a vision. We would like it that people have low barrier access to services in emergency departments wherever they step into an emergency department. So if they have a need, if they use substances and they desire services related to this problem, doesn't matter which emergency department they step into in Vancouver Coastal Health, and I've given you pictures of the dozen emergency departments in Vancouver Coastal Health here, but you can fill in and imagine emergency departments all over the province and all over Canada. They should have access to basic services, and those services should be of a certain standard, and it shouldn't matter where you walk into the emergency department, whether it is rural or urban, community or academic. To kind of give a little bit of history, I want to go back to where I was a little over 4 years ago, the last time I presented to this group. And you can see that it's a very similar presentation. It's about the implementation of interventions or opioid agonist therapy in the emergency department, not about the evaluation of the implementation, but of the implementation itself. And here the focus was on opioid agonist therapy and not on a package of interventions for opioid use disorder. You can see also that some of the logos have changed in the meantime. It used to be Chaos, and Providence now has a new logo. So time has passed. This was a bit of my sort of conceptual model back in 2019. We knew that the emergency department visit was an opportunity to connect a patient who used opiates with services. And we figured that there were lots of different factors playing into whether we could capitalize on this opportunity. There was ED staff factors, there were system factors, there were patient factors, and these are some different areas that we set out to investigate. Specifically, we looked at MD factors, we looked at patient factors, and we thought we would try an intervention that had looked promising of increasing the amount of outreach we were giving our patients to see if this might help them sort of further down the road, connect to care, and end up on opioid agonist therapy. So just want to share a few of those findings with you. This is from the national survey we conducted in over 22 sites across Canada with over 600 responses. And by and large, we found that physicians were very supportive of interventions for people who use opioids in emergency departments. They were supportive of buprenorphine in emergency departments, but in actual practice, only 25% did so relatively frequently. So once a month or more. And the factors that we discovered that were tied to frequent use of buprenorphine in emergency departments was confidence to use it, addiction resources in the emergency department, and opioid use prevalence in the community, which is not surprising. I guess if you see a lot of it, you might be a little bit more comfortable and you might have a few more resources to deal with it. We looked at patient factors also. So the specific intervention we looked at here was buprenorphine to go kits. So this is a way for a patient to receive a supply in the emergency department, to initiate opioid agonist therapy at home, and not to have the extra potential barrier of having to go to a pharmacy. So we were looking at the acceptability of buprenorphine to go kits, and we found that they were quite acceptable. So for almost 43% of people accepted the kits. The factors that were associated with accepting the kit, on the positive side, the strongest one was never having been on opioid agonist therapy before. And on the negative side, not surprisingly, the one that was most associated was having a previous negative experience with buprenorphine. We dug a little bit deeper into patient factors by doing a qualitative study and interviewing 19 people who use opioids and who had sought services in emergency departments. And we really, we got some fantastic input and learned a lot from our participants. I think in terms of the reaction to buprenorphine as an example, people, this participant felt it was a good thing. And that participant also realized the kind of short window we often have with people who use substances, that if they're willing, you should really seize that moment and put something into the person's hand. That same participant said, you know what, buprenorphine and naloxone is great for me, but other people may want something else. And so we shouldn't prioritize buprenorphine and naloxone over everything else. So some great learnings from our patients right there. And just to kind of round out some of our findings, I mentioned we looked into outreach programs, and we found that if we could do a bit of a concentrated outreach program with a minimum of or targeted 4 visits over the course of a year, we could increase initiation of opioid agonist therapy, and we could also increase engagement in care. And so there's the sort of blue line is sort of the best case scenario, and we did some sensitivity analyses with worst case scenarios, and we still had a positive signal as to the effect of our intensive outreach program. So we're starting to understand a bit about the different factors that play into the delivery of opioid-related services in emergency departments. We know that for the most part, physicians are willing. We know for the most part, patients are willing. But here are the actual numbers. So this is from St. Paul's 2019-2020. We looked at over 300 patients, and you can see that of the people who are not on opioid agonist therapy, only 6% received opioid agonist therapy. And in terms of receiving any intervention at all for opiate use disorder, whether it's harm reduction or addiction medicine consultation or opioid agonist therapy, less than 15% got any intervention at all during their emergency department stay. So we have lots of room to improve. So there's willingness on the patient side and on the provider side, but it is not happening in practice. And we're not alone in facing the struggle. So this is happening across North America and across Canada. So I've picked two examples from two Canadian examples. One is take-home naloxone in Alberta, and they looked at people who had suffered opioid poisonings, and 50% of those received take-home naloxone, which is actually good compared to some of our numbers, but I think they were surprised to some degree by this negative result that they were hoping for a higher percentage of people who had suffered an opioid poisoning would walk out of the emergency department with a take-home naloxone kit. And here, the next study I have there is a study by Tina Hu outside of or in Ontario, and she looked at opioid agonist initiation after opioid poisoning visits in the emergency department. And this is from 2020, and only between 5 and 6% received opioid agonist therapy during those visits. So again, quite low. And this is kind of what is happening in practice. These were sort of chart reviews, and this is what's happening in practice. This is not in the context of a study. So here we are with this sort of conceptual map. Again, we have been able to investigate and gotten some answers around MD factors and patient factors. We have a little bit more of a clue as to whether outreach could be useful. Now we're starting to look at outcomes related to this previous work we began, specifically retention, healthcare utilization, and survival. And so we've now linked this data with pop data, BC data, and we're in the process of analyzing it. And as anybody here who's worked with pop data, BC data sets know that it's a sort of a laborious process and always takes longer than you think it should. But we also know that something is not working. So we're beginning to have greater understanding, and we're also having a greater understanding that there are multiple barriers on the provider side, on the patient side, on the system side. And so we're not getting to where we want to be in terms of patients who need services receiving services. And based on our work and the work of others in the US and Canada, I've listed sort of a number of barriers that we know that, and some barriers are specific to providers, some are ED staff, some barriers are specific to patients, some barriers are specific to the patient, some are kind of overarching. So time, for example. So patients leave emergency departments because the wait is too long. Providers may not offer interventions because they're rushed. They don't have enough time. And we have long waiting times, ED crowding, and that increases the waiting time. So all these different factors are related. The good news is some of these factors we can intervene on. So I put in green the ones that looking at, hey, we should be able to intervene on that. If physicians are lacking in confidence to use buprenorphine and other emergency department interventions, then yeah, we can deliver training. If there are not enough resources, that's something we can also augment, and both patient-facing resources and ED staff-facing resources so that we could lower the barriers. So those are things that are quite easy to intervene on. The yellow ones are question marks. I think we can influence them, but we may not be able to fix them. For example, we can implement or have stigma reduction courses in emergency departments, but in the end, we cannot control if an individual patient passing through the emergency department experiences or feels stigma or not. That's a very subjective piece, and we have a long way to go, and some of that is outside of our control. And I've also put in red some of the other things that are outside of our control. So some of the system issues that affect long waiting times and ED crowding, we can't control. If another healthcare crisis arises, such as COVID, we can't control that either. And if the patient is absolutely not contemplative about their substance use, we can't control that, or only perhaps in a very small way by continuing to be sort of a friendly face and let them know that the door is open if and when they're ready, but not something that we can influence in the short term. So as we gain understanding of these barriers, there have been various implementation efforts across North America to try to overcome these. And I've just picked a few to show you, which I think are interesting either in their scope or in their learnings. And the first one I'm choosing to share with you is run from Gail D'Onofrio and colleagues about implementation facilitation. And for those of you who don't work in this area, Gail D'Onofrio is sort of the grand wizard of ED interventions for opioid use disorder. And she wrote the landmark paper in 2015, which showed that buprenorphine in emergency departments was possible and that it had a positive impact on outcomes. And she's done lots of amazing work since that time. And she's also encountered, and others in her group have uncovered many barriers. And this is an attempt to overcome some of these barriers with a technique called implementation facilitation, which a lot of the things are maybe self-evident, but they can be bundles in a package to implement interventions, whether it's related to substance use or to other things. It includes finding local champions, doing some targeted education, having computer reminders. It can be a whole range of things, but to really not just sort of dump a new resource or dump an intervention into a new site, but to really support the team over a period of time in trying to adopt and implement these interventions. And you can see they had some hospitals that were sort of the baseline is before the intervention, or I should say before the implementation, and after the yellow is, or the orange is after the implementation. You can see they really had large increases in their the amount of buprenorphine that they were giving. That's what we're seeing on the left. And in terms of they even had some longer term benefits of people being on opioid agonist therapy at 30 days. So quite promising. And there are a lot of things that are quite useful in this implementation facilitation package. But just to sort of highlight that you can still see that even with all these efforts, only 15% of people were receiving buprenorphine during their emergency department encounters. And these are people who had been identified with opioid use disorder and would be candidates to be on it. Now, I've also mentioned, I mean, we don't know what the optimum level of provision is, and maybe that'll depend on sites and the patient population. And for example, we know from our patient population that not everybody wants buprenorphine, and that's fine. But so there may be, we may or may not get higher than 15%. Here is an example where they did get quite a bit higher than 15%. Very impressive project in California with 52 different emergency departments. This is part of the state-funded CA Bridge program, and they implemented sort of better systems to detect opioid use disorder, better ways to actually deliver it, either by prescribing it or by administering it. And you can see that they had big sustained increases over the course of the project. They had a bit of a downturn during COVID, but then recovered. And in this study, about 60%, almost 60% of people who were eligible received buprenorphine. So extremely high. And again, we don't know, I don't have other details to share with you about the patient population and whether they were opioid agonist therapy naive or not, but 60% is quite amazing, and that may not be something that is achievable in our setting. Another example is from Philadelphia. These were three urban hospitals in Philadelphia where they looked at buprenorphine administration pre and post implementation of a package and they saw big increases in opioid provision from 3 to 23% post implementation, and not just opioid agonist therapy, but also other interventions such as naloxone provision. And this one I like because they used a lot of computer algorithms and other things to help them screen and deliver the intervention. Closer to home, this is one of the largest scale implementation efforts. This is from Alberta Health Services from June 2018 to 2020. And they implemented in 107 different hospitals, emergency departments. So very impressive implementation efforts. They definitely did get a sustained increase in the number of people who were starting on buprenorphine. But if you look at the actual numbers, it's still not a super high percentage of the people who were potentially eligible receiving buprenorphine. Here it was 17%. So again, as I mentioned, we don't know what that optimum number is, that target number is, and it's likely to be different in different populations. And this is to show you that not all implementation efforts are successful, but we need to study these techniques and find out what works and what doesn't. So this is another study that involved Gail D'Onofrio's team. It involved 18 hospitals across 5 states in the United States. So really big project. And they had something called Embed, which were these decision tools that were embedded into the electronic medical record. So these were reminders and other functions or guides telling you how to do certain things, how to dose buprenorphine, how to respond to certain situations. And that did not really improve the provision of buprenorphine, which is what they were looking at. So usual care was 12%, with the intervention 12.5. You can see that there was some difference. Again, this had nothing to do with the implementation itself, but just academic centers seemed to be a little bit better at providing this intervention. So now that's sort of the background on implementation efforts around North America. So now I want to bring you back to Vancouver Coastal Health and tell you a little bit about the work I'm doing with my regional substance use lead role. And so for the last couple of years, we've been working on an initiative called CIRCUIT, which stands for ED Substance Use Response Kit. And it focuses on 3 priority areas identified by CAPE, which is the Canadian Association of Emergency Physicians. And these 3 areas are harm reduction, opioid agonist therapy, and transition of care as areas that every emergency department should be able to provide services in these areas. And it really should be is the standard of care. So these are some of the things that we're working on in our regional initiatives. So we have produced standardized safer consumption supplies. So here's one example on the left with some injection supplies. There are also some inhalation supplies, and these are sort of standard packaged, because it used to be that this was something that staff would have to sort of assemble off the side of their desk. Now it's available for ordering on a regional level. And with a sort of a complete harm reduction package, there are some patient-facing resources, such as where to check your drugs, and some staff resources so that staff can learn more about harm reduction. In terms of opioid agonist therapy, there's sort of 2 components. One is initiation and one is maintenance or continuation. On the initiation side, we have focused on buprenorphine because that is typically the easiest one or the best studied one in terms of implementing in the emergency department. Also has the best safety profile, so that makes it more acceptable for use in the emergency department. And this is the regionally produced kit. This is the regional induction or instructions for the patients that were developed with the BCCSU. And this is getting, I would say about half of our emergency departments now in BCH have this in some form or another as we're rolling this out. The other piece in terms of opioid agonist therapy was to figure out ways to keep people on therapy. And we focused on missed-dose protocols for the main different types of opioid agonist therapy, so methadone, Cadian, and buprenorphine naloxone, but just trying to simplify the guidance for how people should give a missed dose. And sometimes it's not even a missed dose. Sometimes it's just you want to facilitate the patient staying in the emergency department so they can get the care they need and not be worried about making it to the pharmacy before it closes. So that's another piece of our implementation package. And then the last one is the transitions to care. So right now, for any of you who worked in this area, the system is difficult to navigate. It's difficult to navigate for patients. It's difficult to navigate for staff. And what we'd like there to be is a pretty clear roadmap for each facility. And this is just one example from one facility, but we're working with each individual facility to have a roadmap for them. So day or night, whatever staff is involved, there's sort of a clearer way forward into how we connect this patient to ongoing care in terms of addiction care. And so far we've implemented in 3 emergency departments out of the 13 in the BCH region. We've been to Richmond, to Lionsgate, and to St. Paul's. This is a picture from Lionsgate, and we have 3 members of our team here, ranging from left to right. We have a peer navigator, we have a nurse educator, and we have one of our program administrators. And then behind them is a little booth that was set up in one area of the emergency department in terms of providing some education and some games and other things that's sort of part of the implementation package. You'll see the other thing that's part of the implementation package for any of you who've done this kind of work is the box of Timbits, which always helps. Those little things helps. There was also some coffee provided. So those little things go a long way. We don't have a lot of data so far on sort of the success of our implementation efforts, and I'm going to come back to that data issue in a minute. So what strategies are we using to help with our implementation? And here, we've learned from previous implementation efforts within VCH, within the region, within elsewhere in BC. But as you can see, these are a lot of the things that were studied and used in these other implementation efforts I mentioned for opioid-related interventions across North America. And we have physician champions, peer navigators, training, pathways, patient and staff resources, some screening, electronic screening tools, and some performance feedback. And we have most of these in use already, and we have a few that sort of are in the final stages of tweaking before release. So these are the tools that we're using as part of our strategy bundle. Just to show you a picture of one, this is a electronic screening tool that looks at a couple years of previous chart data. So if the patient did prevent previously with a opioid poisoning, there would be a little pop-up to say, hey, this person may use opioids, please screen again, please offer interventions if appropriate. So that's just one example of some of the tools we're developing and fine-tuning over time. So how do we know things are working or not? And so one of the frameworks that's been used by a lot of the studies I mentioned previously and will be a guide for what we're doing is the REAIM PRISM framework, which is very common in implementation science. So the PRISM piece captures the context, and the REAIM captures the strategies and the outcome. And that stands for reach, effectiveness, adoption, implementation, and maintenance. And I'm just going to walk you through a few of those things in the next few slides. So in terms of the contextual factors, there are some sort of basic demographic or other characteristics of the emergency departments we're talking about. There's the size, the rurality, whether it's academic, the sort of percentage of substance use visits it sees, how much part of the patient mix that is. But then there's some other factors. Is it getting hospital leadership support? Is it getting regional support? What is the confidence of the physicians? Are there sufficient addiction care resources? And as we mentioned, I didn't put it up here, but part of the context is also the patient population. And are these people who have a long experience of prior treatment or no experience of prior treatment? And that has a big bearing on the context of the emergency department and the way interventions may be received. So let's go through REAIM. So the first part of REAIM is the R, which stands for reach. And that talks about how well we're reaching the target population. And there are ways to look at this. For example, I've just given you some ideas to start with, but if we're talking about the intervention take-home naloxone kits, for example, for every visit where it should be offered, is the patient being offered this intervention and are they accepting it? So this gives you some idea of, are the patients who need the intervention getting reached? How are we doing in that regard? And so for all these different interventions, and we can look at this across EDs and across time. The next piece in REAIM is the E, and that is the effectiveness of the implementation. And so perhaps the simpler piece of the effectiveness of the implementation is just to figure out, is it working on a sort of process level? Is it doing what we set out to do? So if our goal is to increase the provision of buprenorphine to go counts, kits, then we just count them, on an ED by ED basis. Are the counts going up with time? Now, the next more sophisticated version of that is the actual intervention outcomes. And I'll come back to the data piece around there. So does giving out more buprenorphine to go kits in the emergency department, does it result in starting more people on opioid agonist therapy? Does it reduce healthcare utilization? Does it possibly increase survival? So that's a bit more complex, but certainly it's easier and a more short-term attainable goal to get to monitor the services we're actually delivering in terms of implementation effectiveness. Then we get to the A, which is adoption. So that's looking not at the target audience of patients, but at the target audience of the ED staff and providers. So are the EDs that are supposed to deliver these interventions, are they actually do it? What percentage of encounters are they providing this in, or to what degree have they adopted these measures? And then what percentage of providers? So if you have a group of 100 different emergency physicians in a group, what percentage of them have adopted this intervention and are actually using it? So these are different ways we can track adoption. And then there's the I. The I is the one piece of the REAIM framework that looks specifically at strategies and how these different strategies are working both quantitatively and qualitatively. So if you look, for example, at training, it might be, how many sessions have been delivered, what percentage of staff have been reached, and then the qualitative might be the ratings of the training. Did people find it useful? Did they like it? And again, you can do that for all the sort of different strategies to find quantitative and qualitative measures for your different implementation strategies. And finally, the last piece then of the REAIM is the M, and that's maintenance. So, why do any of these things if there's not a hope that it's actually sustainable? And so this is just looking sort of down the road, whether these interventions are sustained. Are our emergency departments and our emergency providers still delivering these interventions 6 months, 12 months, 18 months down the road? So as I hinted at, data is a big challenge, and we need to be able to measure what we're doing. And I've put up the model for healthcare improvement from the Institute for Healthcare Improvement that many of you are probably familiar with, and that's to some degree where the Plan, Do, Study, Act model has been widely used in quality improvement in healthcare. And the piece that I'll focus on right here is that part that has to do with measurements. How will we know that a change is an improvement? So we have to measure something. We have to measure it before, and we have to measure it after as we go. And for that, we need data. And we actually need it pretty fast, because we need to know as we go, is it working? And can we tweak things in our implementation strategies that will make it better? But if we're not getting this data in close to real time, it's going to be useless. So those are kind of key pieces we need, and we need it to be fast. So we have some data partnerships, and we are on our way to collecting the data we need, but we still have a long way to go. And certainly decision support at VCH is a sort of a key partner and help in this. And I just want to give you one example. We have a VCH regional dashboard, and I just pulled this up this morning. So these are patients with substance use presentations in emergency departments from the last 6 weeks who left before being seen. So you can see the filters on the left-hand side there, and you can see the different weeks over the last 6 weeks, and there were 88 such encounters. There were probably more, but I think what we've established, at least, even if some of these measures are imperfect, they are consistently imperfect, so it's useful to track them over time. So that is one example of data we have in our dashboard. Another example is deaths 30 days after emergency department visits. So here, regional ED visit data has been linked with coroner data so that we can detect, so we can know if patients we're seeing in the emergency department are dying within 30 days of that visit. And you can see that, unfortunately, they're still on, this is across the whole region. You can still, over the last couple of years, you can see that on a monthly basis, there are on average 10 or more people who die 30 days after their ED visit of an opioid poisoning. And that not the majority, but that a good chunk of them in red and in orange are left against medical advice or before being seen. So there's some helpful regional data. Looking on a provincial level, those of you who have used POP Data BC for research know that it's something that takes a long time and is probably not practical for a program that is being implemented. So there's a new platform developed by the Ministry of Health, which shares a lot of the same features as POP Data BC, called Health Data Platform BC. It's developed in conjunction with Health Research BC, and it's trying to make things a bit more accessible in real time. So this is still a work in progress. We have been, VCH Regional Addictions Program has been authorized to access the HDP, and we're trying to get the hang of it in terms of being able to get useful data in close to real time. So that's still a work in progress, but is certainly a bit more promising than the previous data landscape. And then on a national level, we've partnered with Cedrin. Cedrin is led by Corinne Hole, who's one of our colleagues at Vancouver General Hospital. And this was developed for COVID-19, emergency departments patients with COVID-19. But it's in the process of pivoting and starting to work on other conditions such as opioid poisonings. And what Cedrin has done, and I won't go through all the details on the left, but has created an amazing data infrastructure where pretty rapidly, and I'll pull out the piece I wanted to show you, pretty rapidly, data from emergency department encounters is going to be linked with national databases such as NACRS, which is the national database that contains information on emergency department visits. And it's, I would say it's about that database. I think it's about 60% of hospitals in BC participate in that database. That percentage is higher in other provinces. Part of the reason I'm telling you about provincial and national data is because I'm involved in some projects that have both provincial and national reach. So in addition to the work that we're doing that I'm doing in Vancouver Coastal Health, I'm also working with Health Quality BC in the Loud in the ED initiative. And that will kick off this year to do another round of program implementation around interventions for opiate use disorder. There's funding for up to 24 EDs across BC. And we learned a lot from the previous round of LOUD that occurred in 2020. And I think here we will have an opportunity to focus on monitoring and evaluation. So a lot of the same ideas that we're hoping to sort of develop and frameworks that we're hoping to develop and fine tune in VCH could then be applied across the province. Nationally, I'm working with CRISM, and CRISM has a similar project which has been funded now to do implementation science work in 10 pilot EDs across Canada when it comes to opioid use interventions for opioid use disorder, people who use opioids. So those are kind of the next chapters for me. Where do we hope all this will go? Certainly, I hope there will be better tools for people providing care for patients, that it will be easier. There will be more services available in the ED, more resources, so that it will be easier to take care of people who use opioids. This will also be useful for leaders in terms of having more information about how they should implement programs in emergency departments. And of course, this type of information is necessary for policymakers also. So we will have some data eventually on the actual outcomes related to these interventions. And so policymakers will not only be able to sort of help with this new knowledge, optimize what implementation strategies they should use, but also which interventions they should choose and prioritize for funding. Of course, the hoped anticipated outcome is that we can intervene on this sort of vicious cycle that we started with, and that we can take down some barriers and put up some new barriers. So where we can more effectively connect people with community resources. We can get people harm reduction and treatment that they need. We can try to avoid the almost inevitable return to the emergency department. And with time, we can put up a barrier to that final pathway toward death and reduce the number of people dying of opioid poisonings. So that's what I have. I have a large team of people to thank. If anybody wants some references, I can share those as well after the talk. So thanks for your attention, and I'm happy to take some questions.